So to get started, we are interested in finding out what time the work groups would work out best for you all, because even though it's only the end of September, we're already starting to have to put things on the books for 2025. So we want to be very thoughtful about what time we schedule our work groups for next year. So I am going to launch a poll. It's just one. So, and I will give you all a few seconds. So, just so you know, we do these on Tuesdays and Thursdays. We do them the second Tuesday typically of the month, and the last Thursday of the month. We will continue that cadence, but we are looking at whether or not the 12 noon time of day is a good time for most folks or not. Looks like I've got about 80% of the folks have answered. Give it another second. Not surprising that most are answering that the 12 o'clock time is good because you're obviously all here. Right. Okay, I'll go ahead and end that poll. If you're curious, I shared the results with you. I'm sharing the results with you. But you'll get more information on when the work groups are going to be scheduled in the coming weeks. I am trying to advance my slides. There we go. So today's presenter for our Rural Health Work Group is Brent Mikkola. Brent is the manager of the community health at MyMichigan Health. Brent has worked in community health field for nearly 15 years, and the past 8 years have been at MyMichigan Health. Prior to that, he was an exercise physiologist working in cardiac rehab and imaging, conducting stress tests, and worked in the cath lab for Ascension and Bronson. So he's probably known to some of you from having been in those systems or in other areas. Um, Brent is a exercise physiologist by trade with a master's in exercise physiology, an MBA, and currently working on a doctorate in health administration. So with that, I'm going to stop sharing and I'm going to let Brent go ahead and share his slides and get into his presentation.
Thank you very much. Thanks for having me, everybody. Slides here. Okay, are we seeing those?
Yep.
Okay, very good. All right, thanks again for having me here. As stated, I'm Brent Mikkola with MyMichigan Health, and we'll talk a little bit about how MyMichigan is working to impact health equity. First of all, we had to have a commitment to it. So, I mean, this stemmed from years of working within the health equity and SDOH space, and then came along some requirements to advance health equity from, CMS or from JACO and so forth. So we had to create a commitment to that. And what that looked like for us was creating a strategic priority throughout the health system to advance health equity. So we created a strategic objective within the health system for that and developed a governance framework that we had bidirectional reporting, through our operational steering teams and through our work groups in order to ensure that we're doing so correctly using evidence-based practices, using basically decisions based on data and so forth. And then finally, we wanted to make sure that we understood the data aspect of this. So, what did it really mean in health equity? What does that mean to us? How are we ensuring that we're meeting those needs in the community? But in order to do that, we have to ensure that we're collecting the proper data. So we updated we use Epic as our EMR. So we updated Epic to be able to include from the CMS requirement, the 5 SDOHs in transportation, food insecurity, housing, utilities, and interpersonal safety. And so we trained a lot of our staff, registration staff, nurses, and so forth on collecting demographic data and SDOH data. We had our education team create they created a whole module for education around social determinants of health. And then we're also kind of in the process of looking at what does that mean, creating the DEI tab for outcome measures for specific populations. Pneumonia readmissions was one of the priorities for us. So that's what we were looking at first. But over time, that's going to change as we discover more of the needs change for specific populations. This might be diabetes, it might be obesity, it might be maybe an ethnicity or race that we're looking at specifically, especially as we start to expand into other communities that are a little bit more diverse. Quality improvement part of this as well. So participating in not just local but national quality improvement initiatives and community health initiatives, as well as population health. So what does that look like for their priorities? How are we aligning them? And how are we getting information back that tells us that we're doing the right things, or maybe helping others engage in creating models of care that are advancing health equity for other organizations? And the biggest component to this is leadership engagement. We have our senior leadership that is engaged, our CEO, our COO, our chief medical officer, all very well engaged in advancing health equity. So this is really kind of a top-down approach, saying we want to be a leader in this, and we want to make sure we're committed to this. And from there, I mean, it's pretty easy for us. It's sort of been embedded into our culture now. So very important that we have leadership engagement in order to advance health equity. And with that is kind of phased approach. So it wasn't just a let's throw everything into the wind and see what catches. We wanted to make sure we were doing so through a more tactical level. And so kind of our phase one, which was this past year, was development of our Health Equity Council. So this includes various folks in our organization, from community health, population health, quality and safety, and various other teams that would have, some impact from inpatient perspective or from the ambulatory setting. And so this council meets regularly, and we develop a strategic plan identifying those priorities. So I mentioned the pneumonia readmissions, looking at our data internally, and then community data as well. And so we're continuing to improve that data process, analytics, so that we can identify the specific priorities. So creating a strategic plan that identifies the goals. I mean, I know that's something we're continuing to work on. And then also from the demographic perspective, I talked about the education around SDOH. We also had education for our staff around real data, so race, ethnicity, and language, so that we're ensuring, that they know to collect that, how to do so, appropriately and effectively. And we've had education around that for now a year, and we've had quite a few of our workforce go through that education, which has been very helpful. And then engaging key stakeholders. I'll talk a little bit more about that in some of the next slides. But we want to look at some of the community-based organizations, because we know that advancing health equity is not a one-man show. We can't do it on our own. So how are we advancing that? So, in some of our conversations right now, kind of our next steps is how are we working with some of the SDOH hubs that currently exist in the state. There was a priority for the health departments. Are there CIEs that we can engage with? Is there more work with 211 or utilizing other community-based organizations as our resources? And then attesting, of course, to the CMS requirements for those 5 SDOH domains. So phase 2, which is what we've been doing now this year, is, of course, submitting our measures for CMS and the SOGI data, so sexual orientation and gender identity. There's more education that's happening around our health system for that as well. So again, just like the real data, why are we collecting it? How to be sensitive in the topic when you're asking the questions, updating that in our EMRs so that anybody looking at it knows, and understands that. And then why are we collecting it? Why does that matter? So all of that being kind of awareness training for our workforce, and we have goals around how many and who all is going to be engaged in that education, and making sure that our EMR is updated regularly. And then evaluating the SDOH analytic opportunities. So we currently, we measure our SDOHs, how many we're screening. We have our criteria for that for both inpatient and ambulatory setting. And we look at how many we've screened and where they're, what that need is. And then we're continuing to update that, of course, and to improve that process so that we're collecting more and more information. And right now we're looking at how do we evaluate that? How are we extrapolating the data to ensure that we're actually advancing health equity and not just saying, hey, 30% of our patients have transportation issues in Ogama County. Who are these patients? What do they look like? What are their needs? Where are they at? And that's going to help us in decision making for advancing the health equity. And then finally, phase 3 will come into play this coming up year. So having, actual population equity measures for those 5 domains and educating the workforce on SOGI data and EPIC updates for real data. And then additionally, this is where the addressing it comes in. So we're kind of thinking about that all the time and hopefully doing so to some level, but maybe into next year, we're taking all of the analytics now that we did in phase 1 and phase 2 around SOGI data, real data, and analyzing SDOH. How are we now able to gauge with those community-based organizations for the greatest impact? So we're assessing, we're analyzing, and addressing health equity and social determinants of health. And so here's some of the things we've done so far. A lot of this is based on community partnerships. Again, we can't do anything on our own, so we look at various pieces like transportation. We have found that more than a third of our patients will have a transportation issue. We even did our own transportation study several years ago to see exactly what that looked like. The majority of respondents that said that they had a transportation issue were because they had a vehicle, but they couldn't afford to fix it or they couldn't afford the gas. And so that was the main transportation barrier. And then the next being, of course, that they just don't have transportation, followed by some of those needs like they don't, the hospital or the practice that they're going to is in a different county. And so they couldn't use public transportation to get there. So that was how we started developing our own process. We have an actual policy for patient transportation assistance, and we've created partnerships with local transportations in all of our areas, and specifically for Elma here. We have transportation with the Gratiot County Public Transit, some of the local areas, some of the taxi services. And what we did was actually create a voucher. So they have in all of the offices, it's carbon copy paper that has all of our different partnerships listed on it. And, they fill out the information with the patient name, their information, which transportation resource they're using, such as, Gratiot County Public Transit. They just check that box. They're signing that to make sure it's approved and then dating and timing that as well. And they give a copy to the patient and or that transportation unit. And we just get an invoice. So they get the vouchers, they send us the vouchers, we reconcile that and get an invoice for it. And we have an entire algorithm on how this is created. So we utilize other sources too, like Ride Health occasionally, but we've created partnerships with them that Ride Health isn't utilized as often as what we used to because we've created a process that's just more efficient and less expensive. So we have an algorithm. Does the patient have Medicare? Do they have another, do we have a contract with another payer that will help pay for this transportation? We go through this workflow or this algorithm to determine exactly what transportation they need, what their need is. Are there any other resources? And then as the health equity last ditch effort, okay, you need to have transportation to a medical appointment. Here's a voucher for that. In fiscal year 2024, so this is for us, July 1 to June 30th, there were 772 rides out of Elma alone. So this is that's pretty good amount. And so, throughout the health system, there's thousands. So this is just one area alone, what we used to call our central area. So this is Elma, Clare, and Mount Pleasant. And I think about 90% of these are out of Elma specifically. So 772 rides. We can at least anecdotally through high level data say that we're reducing no-shows, improving PCP wait times, and also reducing length of stays for inpatient. So we're not necessarily just providing these for our ambulatory practices, but when people are admitted and then discharged, if they don't have transportation, they may have to stay an extra day. We've learned that very specifically in the behavioral health area. But if they stay another day, that's an expense. It's another day that they have to stay for us. They don't want that. So we provide the transportation. We're able to get them out potentially a day or even 2 days in some cases early. So we're reducing length of stays. One thing we want to get better at from a data perspective is getting more patient level. Let's look at some of these folks who get regular transportation. We know we have some of those frequent flyers who are pretty regular for transportation use for us. let's look at these patients a year ago or 2 years ago prior to us implementing this policy. Were they no-shows more often? And now we've reduced that from a patient perspective. So working on that data piece right now, but we do know that in some of our practices, we've had reduced no-shows since this policy has come into place. So we can at least, say that there's some correlation there. So that's been very helpful. And this is again true for our entire health system. We have contracts in nearly all of our counties. And we're also working out processes right now to help for the transfers. Some counties, transportation authorities will transfer or cross county lines, not all of them. So we're working through, kind of those regional collaborations on their part. I know that some of them all work together and meet regularly, and we're kind of working to help maybe alleviate some of the barriers in their ability to transfer from county to county. So if we have a patient in, Elma, for example, and needs to go to Midland for services, as a specialty need of some sort, we're helping remove that barrier with those transportation authorities to make sure that can happen. Another piece of health equity is education. This is something that's come up a lot in recent years, is people's basic access to, certain education. In our case, it's health education, making sure that everything is at a reading level that they understand, making sure that it's available to them, to meet them where they're at, whether it's, virtual or in person in their location or whatever that might be. And most of all, free. It's difficult to charge for programs and get the attendance you need for the population that you are wanting to achieve. That underserved population generally are those who need this education the most. And if we charge for it, they're not going to be able to afford it. If we make it in person in one area and not in another, then we're not being very equitable. So ensuring that we offer free health education to patients. This includes chronic disease self-management program. We have facilitators for CDSMP. If you're not familiar, CDSMP is a program that was developed out of Stanford. It's a best practice program for chronic disease management. The basic version is essentially what we committed to for the chronic disease self-management. It works through, basically a healthy lifestyle, mental health, behavioral health, stress management, things of that nature. It's a 6-week course. People are there once a week for a couple of hours. Not super intensive, but a little bit more intensive than maybe just a one-time counseling session. So we just started that this year, but that is free of charge, and we offer that virtually, and anybody can attend. Another one is lifestyle medicine. So we have implemented lifestyle medicine into our health system, all in our practices, as a referral for our patients. And this is an intensive program that we offer over the course of 12 weeks. They have 18 sessions, and this includes lab work. So we're able to get health outcomes out of this as well. And we're seeing benefits. 86% of participants are improving their weight and BMI, and I think 64% are improving their A1Cs. So we're seeing massive benefit out of this. And what those numbers look like specifically from, a significance perspective is blood pressures, for example, are increasing by between 4 and 5% for those patients that went through it, which is not necessarily statistically significant, but that's over the course of 12 weeks. That's not a year or 2 years. And so out of this, we've created the Lifestyle Medicine for Life support group so that they can continue to go and continue to get the education and support. And we will monitor those lab works every year so that we can see what the statistical significant benefit is of that program. Currently, that is piloted for free amongst some of our members in the health system, and offering that on a basis, basically, not necessarily for free to the community. It's very expensive for us to implement this, but we do have some funding available for those that meet criteria that would like to attend the class. So for that hard to reach population, we will be able to offer that for free eventually. Prescription for Health. This one kind of connects to food insecurity, which we'll segue into. This is a program where we have education on our own, or we partner with folks such as Michigan State University Extension. This is a PPR program, produce prescription. So if they attend certain amount of classes, they get food vouchers. We've partnered historically with farmers markets. That's what most people do. That's how this started, to get fresh produce. You attend a class where you're learning about the health benefits of fruits and vegetable consumption and so forth. You'll get a voucher and you can take it to the farmers market and exchange that for fresh produce. Some of the struggle we've learned over the years of doing this is that that's only during market season. So how do we expand this out? And with that, we've created partnerships with Spartan Nash, with recently Meyer and Save-A-Lot stores and other local grocers, where they now can give us vouchers with specific UPC codes on them, barcodes, that can only be used for fresh produce. So now they can come into our classes, and they have options. If there's a Save-A-Lot in their area that they shop for, if there's a family fair or a Meyer or a different local grocery, they have options now to be able to utilize different areas, which I think is fantastic and helps a lot from the health equity space, in that now we're meeting these folks a little bit more where we're at than just giving them one option that maybe they have to travel for. Family fare isn't everywhere. So, some of our locations don't have that. So they couldn't offer those classes. But now some of these other partnerships that we have been able to expand those out. So, and that is, from a health equity perspective, advancing food insecurity, which we've also, into the next topic, for food pharmacies, into our practices. So in Elma, for example, we have our practices there that have a food pharmacy. We have partnerships with Greater Lansing Food Bank, where we have basically food bags, backpacks. These are meant specifically for children. So we call them weekend kits. And if they identify that they have any kind of food insecurity in any way, whether it's through our SDOH assessments or anything else, we can provide them a bag. And in Elma, just this past year, was nearly 1,000 weekend meal kits. And the exact number was 997, I think. So that's quite a bit. And that's just in one area. And we have these throughout our health system, and we're continuing to expand and scale that program out. So that's, again, a partnership with the food bank. So in this area in particular, it's the Greater Lansing Food Bank, and some of our practices up in North and Northeast area, that's a Food Bank of Eastern Michigan partnership. So they've been very helpful. It's kind of new, even for the food banks. It's kind of a new type of partnership for them. So this was sort of paved the way a little bit. And that's nice. And we're starting to see others kind of ask questions and see what else can we do with these food pharmacies the way that you're operating them. So that's very helpful. Another piece to this is community health workers. This has been a long project for MyMichigan Health to determine how to make them work. As all of you know, I'm sure all of you have been involved in this work. Community health workers, until recently, was not a reimbursable service. So it was very difficult to kind of discover that ROI, and for organizations, health systems in particular, to commit to that. And so now we have community health workers across our health system, including in Elma, where they're integrated into our practices and into our medical centers. And we've developed a referral process. So within our EMR, we now can refer to our community health workers. If there is an SDOH positive assessment inpatient, that will get automatically triggers a referral to our post-acute care team, our case managers, and they will work with our CHWs on those resources. So that's been very helpful to have that referral process built in. We have workflows for our practices and for inpatients. And then, of course, they're connecting on a community level. We also have what we call our continuing care clinic. So in Elma specifically, if a patient does not have a PCP or can't get to their PCP in a certain amount of time once they're discharged from the hospital, they will go to a provider in what we call our continuing care clinic. It's basically an intermediary in between them being discharged and the time that they're seen by a PCP or a specialist. And these community health workers, the one in Elma, we have a discharge checklist. So they will actually go prior to a patient being discharged, work with them on any SDOH barriers, going through that checklist with them and making sure that they're able to, have a PCP, or if they need the continuing care clinic, and then again, connecting them to any community resources that they have. So that's one way that they've been integrated into our facilities. It looks a little bit different in each area based on the need and what else is available in the community that we're easily able to refer to. But we're looking at right now in that area about 20 referrals a week to our community health worker from our practices. And then it's a little bit more, it's a handful more, I think 4 or 5 a week out of our continuing care clinic that they're working with. So pretty reasonable amount of work. And I think that we're hoping to increase the capacity as we're starting to learn more and develop billing processes and whatnot for our community health workers for Medicaid and Medicare. And then, of course, we have our community health needs assessment. So we work collaboratively across the state with MyThrive, with Mahia, various action agencies and other collaborative assessments to complete our community health needs assessment report and then build out our community health improvement plan. And we are at a point now with our Health Equity Council that we're working together with the needs assessment, the CHIP, the Community Health Improvement Plan, and our Health Equity Council in order to ensure that we have our metrics within our Community Health Improvement Plan that are equitable and meeting those health equity needs. So in my team, we always are focusing on access and health equity when we create our strategies, but now we want to make sure that our measurements, our baselines, our metrics for improvement are something that we can definitively measure that we're improving health equity. And so a little bit more on the community health workers piece of this. We have nationally aligned and trained certified CHWs that are also certified to complete advanced care planning. So they complete ACPs across our health system as well. They do a lot of the SDOH work for us, as I said, and they meet some of the needs from CMS and JCO around our top priorities for housing and those other top 5 needs that CMS requires. And a couple of other areas that we've had them work in with some of our care gaps. So quality care gaps, diabetic eye exams, the blood pressure initiatives that we had. We would pull gaps and we'll have our CHWs work through some of those diabetic eye exam gaps. Was it because we just didn't get the exam reported to us, or have they not received that? So once we pull those reports, they can reach directly out to patients and work with them on those quality measures to make sure that they get in and seen, or we can reach out to whoever provided that eye exam for them. We can get that information put into our EMR, so then it's no longer a gap for us. Blood pressure specifically, we piloted a program in one area and then expanded that into ELMA and into our continuing care clinic. We had some funding for blood pressure cuffs and monitors for people to take home. So if they were hypertensive, had that diagnosis, we were asking the question, do you have a blood pressure monitor at home? Can you get one? Can you afford one? If not, again, an algorithm was created to identify whether or not that we should be giving them one. And our community health workers were some of those folks that were working with our staff in the practices to say, yes, so we're going to be able to give you one. I've got a box of them. Here there is. What size cuff do you need? And also here's some other resources that might be able to help, such as those free education that we offer, such as chronic disease self-management or lifestyle medicine. So that's how they were helping some of our quality gaps as well. Our goal across the system, just kind of for us, is to have 15 CHWs across our entire health system. That's not necessarily hired new employees. We have certain people in positions where they're already working with patients. Some of our social workers or our patient care navigators or other positions where they're working with a patient on social determinants. So now we want to get them trained as a CHW so that they have a little bit more of kind of the leg up, I guess, so to speak, so that they're using best practices and addressing those social determinants. Another avenue was through a grant that we had with these CHWs to help improve vaccination efforts. So we pulled gaps on child well visits. So over the course of 1 year in 2023, we had, out of all of our child well visit gaps that they pulled out, there's 3,200 phone visits completed by our community health workers. And out of those, they were able to schedule those appointments, and 488 of those were completed. And we discovered that 34% of them also had an identified need. So when they reached out to fill this care gap, we also asked the SDOH questions, and over 30% had a need, and we were able to help 50% of them, and we're reporting that to various payers as well. We did surveys and education around vaccinations, and you see some of the benefit there was in 18% increase in flu vaccinations, COVID vaccinations, and then childhood immunizations for us, and that also led to impacting quality performance payments. So more quality metrics there that our CHWs were able to help with. So that was great. Ideally, that would lead, and this is confidence, by the way. This isn't necessarily that we increase childhood immunizations by 6%. We increase the confidence level in that demographic by 6%. So ideally, that would lead to more impact and higher quality. And these are just some of those, health offerings that I was discussing before. We offer nutrition education. Garden Plate Wellness is a program we offer in our schools. This connects children to, ideally 6th graders, 7th graders, connects them to agriculture information, teaches about metabolism, healthy choices, and food production, and so forth. This is a large program, connects to a lot of others. It's sort of kind of an umbrella term for several other little programs that we have in nutrition education, all free of charge, partnerships with the schools. partnerships with certain ISDs and RESDs and area agencies to offer. Go Thrive is also a part of that, which is ideally for children and their families. This is health education, and our providers can refer to all these if they have a child that's maybe is obese or maybe has already pre-onset diabetes and so forth. How are we meeting those needs? Grow and Grills is part of that garden plate wellness program. Essentially, that connects them back into the community outside of the school. We have what we call our My Kitchen teaching series. This connects some of our lifestyle medicine education. We have an actual kitchen. We call it a mobile kitchen, not very mobile. It's a little heavy. It is on wheels. So I guess we can move it around from one side of the room to the other, but that's about it. But this is free. It's in-person and virtual. So we have an in-person class attending while also having a camera set right there. There's cameras that oversee this little cooking workstation, and we have dietitians and one of our nurse educators that run this program, and that's free of charge. And kind of going through some of those with our classes with MSU Extension, our gardening programs, and so forth. For mental wellness, we have our Bridge to Belonging program. This is just one example, and this is a lot of our social connections. So, we have our behavioral health team that works with like senior centers and other council on aging groups to offer this type of work. For maternal and infant health, we have our prenatal and childbirth classes. We have offered centering pregnancy in some of our areas and car seat installation. Lung health, we have tobacco cessation. We partnered with schools with the American Lung Association's Vape Free Initiative, the NOT program, Not on Tobacco, and In Depth. We have 16 different schools across our area that we have helped recreate policies around tobacco cessation. So if a student is caught with any kind of tobacco, whether it be vape, is a vape free initiative, but if it's vape or chewing tobacco or smoking, generally they end up being suspended or kicked out of school or what have you. But we've worked with them to implement a process so that they don't have to be kicked out. They have a choice. Rather than being suspended from school, why not go through this tobacco cessation program? And we offer those services. Freedom from smoking. I know a lot of people offer those programs. Those are free of charge through us as well. And I won't go through the rest of these in any kind of detail, but hands-only CPR, Heart Saver, Heart First Aid. We work with the schools to make sure that we're offering those. We work with other agencies and organizations so that all of these are offered as abundantly as possible. Most of our schools are Heart Saver certified so that we have our educators that will go in and ensure that they keep up with that. And then from community support, we have various support groups, our speakers bureau. So if an organization or agency has any kind of event coming up that they want a speaker for, and it might be health related or what have you, then they can reach out to us and we can provide that education to them. My team has a list of people within our health system that is interested in doing that kind of education out in the community. And we can certainly find other folks too, if those people are busy or whatnot. So offer those as well. So that's just some of what we do. I mean, there's a lot that can go into each of those. These are definitely not something that we offer on our own. As stated before, health equity, it's something that we have to work with the community. Social determinants of health are not, built within our walls, so it's not going to be fixed within our walls. So we have to work with our community partners and ensure that we have certain processes in place that will advance health equity for us to assess those needs through screenings, analyzing that need, and then addressing those needs. And of course, we're continuing to improve our process all the time. And that's all I have for you. Disclosure statement. And then if anybody has any questions, there's my contact info. I'm happy to help elaborate on anything or maybe help implement something if needed for anybody here.
Thanks, Brent. We had a few really good questions coming through in the chat as you were speaking, so I'll kind of walk through those. Elizabeth McLaughlin had asked, and I saw this one come up when you were talking about the transportation aspect, so I think she's referring there, but great work on that. How do you get the reimbursement to them before the appointment? I don't, Elizabeth, if you wanted to unmute and explain any further your question, otherwise.
Sure. Yeah, I guess my question is for like the patients, because if they get them transportation before the appointment, how would they pay for the appointment before they get kind of like the voucher?
You mean paying for the transportation?
Yeah. Yep.
Yep. So the voucher, they are the way that that works. The voucher has our signatures on it and so forth. And so there's like two copies to that. So the physical copy goes to the patient, and the patient is able to give that to the whatever transportation source they're using, and we can set up those appointments. So if it's something where we need it on a certain day and a certain time, we or the patient will actually set up a transportation appointment essentially. So if it's using public health or public transportation at a certain location or at their house, some of them have door-to-door services. So we actually set that up, and that voucher is essentially the payment. So we have that part of our contract with all the public transportation authorities and some of the taxi services are that if you get this voucher, you're reconciling those on a monthly basis, and then you're just invoicing me and I pay those invoices. So they're not paying for it prior or ahead of time.
Got it.
That voucher is essentially the payment to that transportation person. So whoever that resource is, they're saying this is good for a ride. MyMichigan Health is going to pay for it. Does
Okay.
that answer your question?
Yeah, that's awesome. Thank you.
You bet.
Thanks. Another good question from Alex Calloway. Great presentation. Do you all share this information with TJC? This one popped up during the community partnerships slide. They asked us recently for a written plan with baseline and targets and would not let them use CHNA, said it was to be it had to be a hospital data.
Sure. So, I mean, yes and no. I mean, nothing that we're necessarily obligated to do, but we do when asked. Not sure if that answers the question. We share this wherever it's needed. I mean, there are some, reporting obligations that we have, but I mean, it depends on who's asking.
Brent, this is Stephanie. Do you want me to kind of?
Yeah, go ahead, Stephanie. You can jump in there.
So I'm Stephanie Pens. I work at MyMichigan Health as well, and I focus on health equity in the acute side as well. And we have a health equity plan for the hospital, and that's kind of when you talked about priority populations and outcomes. That's where we look at kind of our quality dashboards and our plans and quality, and start aligning some of those DE&I that lens to outcomes. So we focus on pneumonia readmissions. So that is kind of what we present. We have PDSAs around that. So that's how we handle it with our accrediting bodies on the hospital side, if that makes sense.
And we do have to report and attest that we are, collecting this information and analyzing this information. So Joint Commission and CMS, we do have to attest to that.
Alex, I saw that you had your hand up. Did you get your question answered, or did you have another question?
Yeah, I sent Stephanie a separate message. I just it's under a national patient safety goal standard, so we've just sort of been struggling about like what do we say and how much has to be hospital versus what we're doing with community partners. So anyway, I sent Stephanie a message to see if we could see hers maybe, but if not, I totally understand. So thanks a lot.
No, it's nothing secretive. I'm happy to share.
Thanks for jumping in there, Stephanie.
Great, thank you. All right, Catherine Scholl has a question about how do you get the community health offerings information to families and children? Do you do that at well visits or at schools?
Yeah, great question. There's probably several answers to this really. In our practices, they have access. We've created community resources. So on our own intranet, our internal website, we have a community health page, and that has all of the resources for food, housing, utilities, etc., all the contact information for every county that we serve. So they're county based. And so our practices have the ability to print those out and hand those out if needed. We've also, yes, in schools, we've been able to distribute those through there, and then various other collaboratives, action agencies, our health and human services councils, food collaboratives. We've also shared a lot of that information out there so people know what resources exist, what partnerships exist. We go to our regular practice meetings in all of our areas to make sure that all of our providers and our nurses and our wellness nurses are all aware of this information, where to find it, and how to get that to our patients. So yeah, a little bit of all of them. There's kind of ways it's shared in multiple areas, both in the community and within our practices and within our medical centers. So it kind of goes around in quite a few areas.
Do you have any staff that is actually going to the schools to do any of that education?
Yes.
So
Yes,
like I
we do.
saw a couple slides before, you had there, I noticed there was like the Stop the Bleed, I thought I saw.
Yep. Yep.
Um, and like just the vaping, just on like a personal note, like I have a daughter in middle school and like I don't think that's anything that's ever been shared at her school. And I was
Mhm.
just curious how you're disseminating that information in the community.
Yeah, I mean, some of these things are not necessarily disseminated community-wide, like the
Hmm.
tobacco cessation in the schools. It's a little bit more just policy driven, and
Hmm.
it's an opportunity. It's not necessarily that we're throwing it out there saying, "Hey, we have these classes available." But yeah, we have staff. So I have a community health staff, and
Hmm.
within our community health, we have myself. We have supervisors that kind of work on more of the strategic level, and then we have community health educators. Those are the ones who are trained to teach Stop the Bleed, the Heart Saver classes, the not and in-depth classes in the schools. Yeah, we have our own designated staff that are out in the community doing this education and in the schools doing the education. So, when the programs come up, we have flyers, we have social media. Those things are shared generally, out and about, and it just kind of depends on the location and some of
Hmm.
the how it's wanted. Some schools, I'm not going to name them, but they're a little bit more reserved in sharing that information. It's
Sure.
kind of, they don't want everybody to know that there's a tobacco cessation program, because they don't want people to know that, well, why do we have to have that? Is there really that big of a tobacco issue? So they don't want that on the forefront, kind of thing. So
Mm.
it varies based on location and school and so forth. But usually when the programs come up and it's widely shared, we create flyers, social media, again using our community collaboratives. And then the school's resources. So if it's something in the school, we utilize their counselors, and anybody else that's available that might
Mm.
be a good
Yeah,
connection.
that makes sense. And I would think something like the heart saver and the first aid would be something that wouldn't be too contested, I guess, bringing that into this. I would think. Maybe the vaping is a little more of a sensitive topic, but I just
Yep.
thought those slides were great. Thank you for sharing that.
Yeah, you're welcome. And we have really good turnout for some of the hands-only CPR. I mean, we have
Mm.
waiting lists, and we have to do classes multiple times at schools because we do really well with attendance there. And oftentimes in some schools, it's not that we necessarily have to uh, you know provide a flyer and people register. We work with a science class, and we say we're going to be here all day with this science class to teach them, and then we'll
Okay.
be back next week. That way we're hitting all of the students throughout a year. So it's not necessarily something we have to advertise. We just connect with that school to make sure that that's offered.
That's great. Thank you so much.
Yeah, you bet.
On the topic of the tobacco sensation, Sarah Chung just shared that she recently learned that teens are now using flavored nicotine pouches. Zyn is one brand, and maybe something for folks to include in the program about vaping and smoking, etc. So thank you for sharing that bit of
Another
information.
And something more that we've seen is, I mean, you guys probably have seen it, the vaping. There was one school that we did a survey, and over 80% of them had at least tried vaping. And I think it was somewhere around 60% of them have vaped in the last 30 days. And it's starting to get to a point where they're hiding it. You have vape pens that look like markers now, Sharpie markers. So they're taking them into classes and in the schools, and you don't even notice they're there. So along with the flavored, how they're hiding it and trying to get around it, they think it's cool. I mean, all of that is such a struggle for schools, for parents, for community, and for healthcare. Are we prepared to? I mean, we're not going to see the results of these for another 5 or 6 years or longer. Are we prepared to provide the care that's going to be needed for these teenagers that in 10 or 15 years are going to have some form of health impact from that? So certainly an issue. So appreciate that comment too.
That's right, and I have two teenage daughters. I completely feel that comment that you just put in there.
This is terrifying.
New fear unlocked for all parents on the call. 100%, yes.
Yeah, not trying to introduce a bunch of stress into your lives
No,
today.
it's facts.
It's awareness. It's awareness
Yeah.
for all of us as healthcare professionals and parents, and even just, you have nieces, nephews, whatever. Yeah, it's awareness. Thank you. Kyle has a question that I'm going to get to. Did you get any pushback? Did you get much pushback on your organization-wide SOGI training? So switching gears a little bit, and how did you deal with that?
I don't think that we had a ton of pushback. I think most of our pushback was just kind of how we were going to offer that training. Like I said, we had leadership engagement right from the beginning. So, I mean, our chief quality officer is on that council. She's helping us, make sure that that education can happen. Our education team was all for it, making sure that it was, appropriate and developed well. I don't think that we had really a ton of pushback. I think, some of it might have been just around the timing of it and, how we were going to get staff trained in this information. But fortunately, we have a good culture around health equity. So not a ton of that. But I think that the education piece that says why we're doing this is really how you would mitigate any pushback on this. There's a reason for this. There's best practices for this. We didn't create this on our own. We took the best practices around there to make sure that we had the best education possible and that everybody understood the why around this. So it was well received, I think. I don't think that we've had a ton. Stephanie, do you have anything to add to that as far as you were pretty involved in that education piece?
Yeah, the only thing I can add is, of course, there's going to be some frontline staff that are, going to give a little pushback and maybe even be defiant. But we put that into policies that it is an expectation of staff at MyMichigan Health. So at that point, it is a performance discussion with the employees if they were to have any pushback or maybe treat someone badly because of race, ethnicity, language, sexual orientation. It's not acceptable. Our leadership said we will not accept this from our staff, and that was really the support we needed to make sure that we can push it out across the entire organization.
Great, lots and lots of great questions here. In the interest of time, because I know you all have very busy schedules, please feel free to continue putting questions in, but I am going to go ahead and share my slides so that we can just touch base a little bit on what is coming up with MVC. If questions pop up as I'm doing this, we'll revisit those here at the end. So the next Rural Health Work Group and the last Rural Health Work Group of 2024 is coming up, happening on December 12th. If you haven't registered yet, please do so. If you've been at all the other Rural Health Work Groups, you might as well come to this one so you can get your engagement points for that. We are still seeking presenters for our November 5th pre-op testing work group, our November 21st cardiac rehab, and our December 12th rural health work group does not have a presenter yet. So I know I said come, we will have somebody just as great as the other ones have been, so you won't be disappointed. I know that because all of our members have been really great. Other upcoming work groups that we have are a Health in Action work group on October 8th. We've got Hospital Care at Home presenting their program from Michigan Medicine. We have a sepsis work group in October on October 17th around sepsis that will be presented by AK from Garden City Hospital. All of these work groups, as a reminder, happen from 12 noon to 1 p.m. Other upcoming events, you may have seen this if you've been paying attention to any of the collaborative meeting registration emails that have been going out. If you're not getting our emails, please let me know. We'll make sure that you do get these invitations. But we've got a networking dinner the evening before the fall collaborative meeting. So especially for those of you that have to travel kind of far and are planning on staying in the area, come and have dinner on us. We would love to network with you and chat about all the different things that you're doing, learn more about you, and help you learn more about MVC and just some casual conversation. And then, of course, our fall collaborative wide meeting on October 25th from 10 to 3. You can still register for that. And just announced today, right now, for those of you that will be going to the Michigan Center for Rural Health, MVC has signed up to do an exhibitor table so at that critical access conference going on November 7th to the 8th. So please come see us there if you're planning on attending that. So that was what I wanted to make sure to get covered. Shannon has just put in for you to complete the feedback survey and get credit for attending today. Shannon just put that link in there that will also be sent around when we send our follow-up email with the resources from today's work group. And I am just scrolling. I don't see that we got any other questions while I was sharing that information. So now's your chance. If you want to unmute or... Okay. Brent, thank you so much. Really great work that you guys are doing. Very valuable information to share across the collaborative. We really appreciate it.
Yeah, absolutely. Thank you. Appreciate everybody having me on the call today.
Thank you.
Thanks.